Welcome to the Topics in Geriatric Health Literacy Active Learning Series. This is session 5, and I'm thrilled to say that this is the last session in this series for this basic program in geriatric health literacy. This is sponsored and put together by the East Texas Geriatric Education Center. And as many of you know, I am Tony Denuzzo, who is the director of the center. And we've been putting on these kinds of programs to benefit the level of geriatric education for health practitioners and students in health professions. We cover a wide range of disciplines. And today is going to really bring that out, because we're not only going to have a panel of residents put together by Dr. Lee Grumbles to discuss culture and the effects of culture on health literacy, but also a panel for interdisciplinary or interprofessional teamwork and its effects and their roles in geriatric health literacy. I'd like to also acknowledge our partnership with the East Texas AHEC and our coordinators from all our regions that we cover in the 60 counties of our target area. It's a pretty simple agenda today. Just we're going to have these two panels. One panel talking about the effects of culture on geriatric health literacy and be moderated by Dr. Lee Grumbles. We'll have a short break, and then we'll set up for the second panel to look at solutions possibly in terms of improving geriatric health literacy, and that's a panel of interprofessional disciplines. And to me, that kind of will bring together everything that we've talked about for the past 5-6 months. And I think it'll be a really nice way to end this on a really positive note. Please be sure to complete evaluations. I'll be talking about that a few times. As I mentioned that this is the last in our session, please start thinking about and looking for the next session that will be advanced topics. And I was wondering, where do we go from here? Well, we're going to figure that out. We're hoping to be able to apply a lot of the things that we've talked about in these 5 sessions, maybe possibly with case studies, more standardized patients, really putting into practice many of the concepts and components of geriatric health literacy that we've already talked about. And that will probably start again in January 2010, okay, and probably run for the same amount of time through June of 2010. It'll be a very similar setup. 3 hours on the 3rd Wednesday from 12 to 3 p.m. once a month. I'd like to acknowledge our sites that we teleconference to. This is always an interesting game because they change where they're located each time. So they make me guess who's who. But I do know that we have Lamar University, and that's Dr. Nancy Bloom, who's going to be on the panel but in the professional discussion representing nursing. In the middle, we have Baylor University in Waco. I could always tell because I love their tables. That's a beautiful table. Sure. We have SFA in Nacogdoches, run by Mark Scott, our AHEC coordinator out there. And here we have Pecan Valley University of Houston Victoria, run by Pecan Valley, and Paula. And Robin might be there, but Paula Crawford is our coordinator for Pecan Valley AHEC. I'd like to acknowledge in Waco our AHEC coordinator, Amanda Thomas, who's with Brazos AHEC. Excuse me. All right. And in Lamar, we have Terry Dickerson, who is our coastal AHEC coordinator for that area. We offer CME credits for this session. We offer 3 hours. And just all you really need to do is just sign in and complete the evaluation form that's on the table. That would be this one here if you want CME credits for MDs, DOs, nurse practitioners, and physician assistants. Okay. We offer continuing nursing education credits for RNs and LVNs, 3.2 contact hours, and there is a separate evaluation form for the nurses in this little packet right here if you'd like to get some CNE. Okay. CEUs for social workers, that's in the same evaluation form as that for the CME. It's this one. And you get 0.3 CEUs for this 3-hour session. And finally, physical therapists and occupational therapists, just fill out the general evaluation form for this session. And we also ask anybody could fill this out. Everybody is really welcome to do this because this really helps us determine whether we did what we needed to do. And we have a PGC website, has a lot of materials that you might want to take a look at some point. Has a lot of good materials, good programs that we've done in the past. Finally, we have a participant profile. This is very important. If you could fill this out, HRSA likes to know who we contact in terms of not only your disciplines, but whether you work in areas of, that have shortages of health professions and some other things about your background. So if you could fill this out, it takes just about 5 minutes. All right, any questions on CE or anything I've talked about so far? Cool. All right, our first session, we're going to be looking at the role of culture. And this is going to be moderated and put together by Dr. Lee Grumbles, who provided that very amazing session that we did last month on breaking bad news. That's her bio that you can look at in your handouts and just take a look. We all more or less know what she's involved with. And so we don't have to spend a whole lot more time. I'll let you just get her up here and do her portion.
And then we're going to have a panel discussion to try to learn a little bit about the diverse culture that we have available here at UTMB to learn from. We have 3 objectives today. Our first objective is we're going to define what cultural awareness is. We're going to define what cultural sensitivity is. And then we're going to define what cultural competency is. Our second objective is we're going to recognize the impact that cultural competency has on health literacy. And the last thing is we're going to practice listening to those with cultural differences and self-reflect on your personal acceptance of those with different cultures. And that's what the panel is going to help us with today. It's that last objective. I want to thank the panel. I'm going to let them introduce themselves to you individually in a few minutes, but this is just to make sure everybody recognizes how appreciative we are that our physician learner staff at UTMB agreed to help us with this project. Now let's get to the first objective. The first objective was to define the 3 terms. Cultural awareness. Cultural awareness is merely a consciousness of one's personal reactions to people who are different. In essence, I would say that the vast majority of people are culturally aware. An example I might give is a white supremacist is culturally aware. They have a consciousness and they know exactly their personal reaction to people who are different from them. So cultural awareness is just the recognition that we're all different, that we come from different values, beliefs, backgrounds, religions, that our cultures are different. But when we start looking at cultural sensitivity, that is the knowing that cultural differences as well as the similarities exist, and we accept that without assigning values of being better or worse, right or wrong, to each of those cultural differences. So when we become cultural sensitive, we move from cultural awareness to an acceptance that all of our differences and all our similarities are okay. That we all have an equal right to have our own assigned values, beliefs, and attitudes. The last definition is the one that we hear the most when we're talking in healthcare education and in education, and that's cultural competence or cultural competency. And that's a set of congruent behaviors, attitudes, and policies that come together in a system or an agency or among professionals, and it enables that system, agency, or professionals to work effectively in cross-cultural situations. So it takes the cultural awareness and fosters cultural sensitivity, and then it actually creates a system within a system, the tools necessary to actually provide a service to people that are across many different cultural situations. There's no way that we can provide cultural competence training for each and every culture that we have and that we're going to be made have interaction with in our healthcare systems. So becoming cultural competent is not to learn about every single culture, every single religion, every single ethnic group. It is to learn how to be sensitive and respectful and learn some basic skills to always be looking for, to be questions to be asked of ones that we're working with to show that we do have cultural competence. So that gets our first objective, was to learn those definitions. Oops, sorry. The next thing I want to do is I want to talk just a little bit about culture defines how healthcare information is received. And this is where cultural diversity actually starts linking up very closely with health literacy. Okay? What does it do? Well, it actually has a lot to do with how we give rights and protections to people. You know, we say everyone, has to be treated equally. Everyone has to be respected. Autonomy has to be respected. Well, depending on the culture, how we apply those rights and those protections vary a little bit from culture to culture. Another thing that the culture defines is how we receive what is considered to be a health problem. What one culture may consider a health problem, and another culture isn't a problem at all. So we have to take that in consideration when we're assigning a problematic state to a health state. Another one is how symptoms and concerns about the problem are expressed. In many cultures, withholding certain information is appropriate. In other cultures, over-reporting symptoms and information may be appropriate. So we have some diversity within how our clients and our patients respond to us with their reporting of symptoms and concerns. We also know who should provide treatment for the problem. Culture has a lot to do with that. There are sometimes gender restrictions on who provides certain types of treatments or care to patients and clients. Sometimes there is even age requirements where people from one culture will not accept maybe information given by a younger generation, and they want to hear it from an older person with more age. So we have to realize that gender and age can actually play a part in how we provide treatment for the patient's problems. And lastly, what type of treatment should be given? Different cultures have different belief systems, restrictions, attitudes about how different problems should be treated, and we need to respect those. One of the things that I realize in practicing palliative medicine is how difficult it is to not assign right and wrong to differences in culture. When I deal with end-of-life issues, sometimes, as many of these physicians sitting in front of me can attest to, we have patients that we believe have moved into the state of futility. Regardless of what we do, we are not going to be able to cure or even to do anything other than prolong the death process in many times. And it's very hard for a physician who realizes their limitations to accept the fact that there are cultures that believe sanctity of life is a heartbeat. And as long as a heart is beating, there is a necessity to perpetuate that heartbeat. And it becomes very difficult to look sometimes and say, that is a culture and that is a belief system, and I have to respect that, and I have to find ways to work with people that have a belief system that are so radically different from my personal belief system. So cultural sensitivity lots of times is just the recognition and then getting control of your own emotions and saying, okay, I've got to pull back here. These are people that I must respect. I must respect their beliefs, their values, their attitudes. And in doing that, I must be open and willing to say that their cultural beliefs and attitudes and values are different from mine. But it doesn't mean that I'm right or that they're right. We just live with different belief systems. Now, the next thing I want to do is I want to have each one of our panelists today spend just 1, maybe 2 minutes at the most introducing who they are and giving you just a little basic snapshot of their cultural, where they came from, kind of what their attitudes, beliefs, religions, ethnicities, associations are that make them culturally different from one another. And some of these residents I know well enough to know what their cultural background is, and some of them I don't. So this is going to be a sharing for everybody. And I'm not really sure what they're going to tell you because this is a panel discussion. I'm just opening it up and going to let them present the information that they want. Then after we kind of introduce them, then I'm going to moderate some questions and have the panel kind of talk a little bit about different things that affect health literacy when we're dealing with elderly people of different cultures.
Lafayette, Louisiana, and I guess just a little bit of background about me. My origins include French Canadian, African Jamaican, and a little bit of Native American, and that's basically what makes up the Creoles in Louisiana. And so there is a lot of beliefs as far as life processes and superstitions and things of that nature that have been passed along to me, and it sort of influences some of the ways I act, some of the ways I believe. And I also was raised as a Christian, not particularly strong in that faith, but it did have some influence on some of the life choices I made.
Good afternoon. My name is Daniel Okoradudu. First of all, I'd like to thank you very much for inviting me for this opportunity. I think it's very important. I am, I guess you'd say, Nigerian American. My parents are Nigerian. They moved to America in their teenage years. I was actually born in Newark, New Jersey. Shortly after I was born, I moved to Nigeria, lived there for about 5 years. Came back to the States at the age of 5 or so, and been living here since then. I was raised Catholic, and now I currently attend Baptist Church. I just wanted to also kind of add a disclaimer, a little misconception that often I hear about Nigeria or Africa as a whole, and that is that Africa it's not a country. So Africa is a continent, actually the second largest continent. And I just say this because often I can't basically represent the whole of Africa, because often people assume I'm Nigerian, so that's how all Africans behave, and even within that, Africa, I'm within Nigeria its own. Nigeria is a very diverse population as well. It basically was a land with multiple different peoples that were basically colonized, and an arbitrary line was drawn. So even within Nigeria, beliefs that I hold, my family holds, is probably different from the next family. So just wanted to share that as well.
Good afternoon. My name is David Schneiderman. I'm a geriatric fellow here at UTMB. I want to thank Dr. Grumbles also for the opportunity. Let me go back a little bit. My grandfather from my dad's side was a Romanian Jew. And from my mother's side, my grandfather was African, from the Peruvian African community. They both married two different Peruvian girls, one from the mountain and one from the coast, that are very different in their lifestyles, physically, and also what they believe in sometimes. And well, my parents, I was born from a Jewish father, a Catholic mother, and I was raised basically in both religions. At the age of 13, I decided to follow the Jewish religion. So that's a little bit of my background: Peruvian, Hispanic, Latin American, Jewish.
I don't know if I can top that, but thanks again, Dr. Grumbles. My name is Marco de los Santos, and I am first generation born in the United States of Mexican-American, Mexican parents, both of them from Spanish descent. I grew up, I was born in the United States, but grew up most of my childhood in Mexico, up to when I was about 14 years old. I came to the United States for high school and then went to Baylor University in Waco, and then returned to Mexico for medical school, and then now here at UTMB. So I consider myself not only bilingual, also bicultural in nature. Half of my life was spent in the U.S. and the other half in Mexico. Other than that, I'm a Catholic, and that's about it.
My name's Audrey Nguyen. I'm a resident here at UTMB. My background, both my parents are Vietnamese, and they both moved here to the U.S. for college, and then they met here and settled in Austin. My mother went to nursing school here in Texas, and I grew up pretty much in Austin my whole life. So my perspective is very Western, since my mom studied Western medicine, and I studied, obviously, Western medicine. But there's still, I can still see a lot of influence in the Vietnamese culture in my family and my extended family that are both here in Texas and back in Vietnam. I am Buddhist. My family is Buddhist. My uncle's actually a monk. So a lot of the influences of the Buddhist religion play into our views on healthcare and death and dying. And that's about it.
Hi, I'm McGhee. I did my residency from UTMB in internal medicine, and I'm currently a geriatrics fellow. I'm originally from Pakistan, and I'm a Muslim.
Got one more.
But I have to add, I'm sorry, I don't know your name, but the second person who's speaking, I mean, Pakistan, or, it's kind of complex because, religiously we're Muslims, and sort of culturally we're actually very sort of similar to India. And the other thing is, I think one thing that's important is whenever you meet somebody from a particular country or culture, it's important to remember that it can be generalized to everyone, because it's always going to depend on what part of the country they're from. So my beliefs would be different from maybe in certain things from somebody from a different part of the country. And also your socioeconomic status, as well as your education background. I also grew up partly in Hong Kong, I should add, and that in itself is very sort of multicultural, and I've been to the U.S. several times, so I'm kind of mixed and maybe it's slightly atypical in that sense. But thank you.
I'm Fariba Taheri. I'm one of the geriatric fellows at UTMB, and thank you, Dr. Grumbles, again.
I don't like the mic is on.
That doesn't amplify.
Yeah.
That you can just use that sound. That's just for recording. So just speak on out there.
Okay, so I was born here in the United States, but I didn't grow up here. I went back to Iran when I was 3. Then I grew up there. Then I came back here for my residency. I had some trips back to the United States, but I came here mainly for my residency, and it was 5 or 6 years ago. So I did my residency in California, then I came here, and right now I'm doing my fellowship in geriatrics at UTMB. And so I grew up in Iran, and I'm Muslim, and I was raised in a Muslim country, but that's it.
Hi, I'm Sahithya Raju. I'm a second year internal medicine resident here. There you go. I was born in India, specifically South India, and I moved to England when I was 3 months old. And I lived there for about 12 years, and then I came to America. And so I've been here for, I think, about 15 years now. So I was actually, even though I've lived kind of in, I guess we say, the Western world for most, or for all of my life, basically, I was still, my parents were very particular to raise me with the influence of our Indian culture and how they were raised in India. And so that, we're Hindu, basically. So we are Hindu, and Hinduism plays a lot into Indian culture in general. And so we are basically brought up with the belief that Hinduism is actually a way of life. And so I, even though, like I said, I was raised mainly in the Western world, we would go to India for 4 months out of every year. We would visit temples, we would practice the religion. So a lot of the way that I live life and the way I practice is influenced by my beliefs growing up in Hinduism in general. And like, I just want to reiterate what other people have said. Just the states in India itself are very different from each other. We have many states. And so even though the majority of people in India are Hindu, they practice it differently, and their beliefs are different. So my beliefs and my family's beliefs, like Daniel was saying, is not necessarily what every Hindu person would believe.
Well, now that we've got to know a little bit about each one of our panelists, what I would like to do now is ask a few questions of the panelists, and they don't all have to answer it. We can kind of just skip around and let people that feel comfortable share something about their culture with some of these questions. The first thing I want to talk about is kind of the discussion that we as healthcare professionals have with informed consent and with advanced directives with our patients of other cultures. I know in some cultures, the discussion of possible bad outcomes might call forth that negative outcome to occur is a very strong belief. Does that belief prevail in any of the cultures that you may represent?
Sorry, the question, Dr. Grumbles, is
that when you believe something, when you discuss about something negative happening, that it's going to happen. So if you talk about signing a DNR, you're going to arrest. If you talk about, advanced directives for terminal diseases in the future and you want to know how to address them, you're calling forth those terminal diseases to occur. Do any of your cultures bear that?
I mean, I think in my culture, it's not so much believing that if you say something that it's negative that it will happen, but I think it's more that it also depends on socioeconomic status, and the more well-off a family is, even in the Hindu religion, the more well-off a family is, the more they will discuss these matters. But I think in the lower socioeconomic statuses, it's more of just not discussing something bad, not necessarily because that bad thing will happen, it's just because they don't want to bring it out into the open. Does that make sense? I don't know if that makes sense. But
Does any of the other cultures have anything similar to that?
I think I can echo what Dr. Raju said a bit. And training in Mexico, you do tend to see a line being blurred of who you actually really want to discuss completely what's going on, and with the fear of even confusing them more about the situation at hand. I think informed consent is a must, and it's one of the pillars of medicine. But training in Mexico, you see that sometimes it confuses the patient. Not so much in the superstitious sense where something might happen, but more so that it adds more of a barrier. It's done, don't get me wrong, but sometimes it's a burden and a barrier.
Okay. What about, I know in some cultures, family believes that the elders, our geriatric elders, should be protected from bad news, that it's okay to discuss it among the children, but yet the elder patriarch, matriarch, we kind of have to protect them in some ways. Does that belief kind of thread through any of y'all's cultures?
Yeah, I think it does. But the two main distinctions, I think, at least for myself, I mean, I'm from Pakistan and I'm a Muslim, is that the distinctions between religion and culture. So religiously, absolutely not. You're supposed to be aware of as much as you can be aware of and make reasonable decisions based on, whatever scientifically available. Culturally, it can be a little different. It has to do, again, with socioeconomic class as well as education. The more educated people are, they tend to be a little more sort of westernized in their approach, where they want to know everything and they might be the ones who are going to be deciding things. Sort of somewhat in the middle class and the lower socioeconomic classes, it's kind of more, physicians tend to have more of a paternalistic attitude, where you're going to be the one who's going to tell the patient what should be done, and the patient's going to kind of go with you. And especially with the diagnosis of cancer, that's a word that's just associated automatically with death. And people are very scared of it. I mean, my uncle personally, he died of lung cancer. And he was, people were kind of hesitant to tell him the diagnosis. I mean, he kind of knew, but at the same time, it's not something that they openly wanted to discuss with him. Because somehow, it had metastasized and it was kind of beyond the stage where it could be treated. So at times there is a tendency, especially with the elders, to want to hold back information, and even the elders to want to go through the kids instead, because it would be devastating for them to kind of handle on their own.
Okay.
I think like in Peru, there's something about it. But it was more in the older generations, like I would say my parents' generations, and probably before that, that's what they learned. When I had the chance to practice in Peru, there were a lot of times that you would have like a 95-year-old mother that one of their kids died, and they were probably abroad or they were nowhere near. It was not a person that they would be in touch with. And the children would try to hide that information from them, basically because they were scared that something wrong would happen to her having such a big news. And it was not once. I mean, it's several times it happened to me. When you get to younger ages where information is so readily available and it's so important to be informed about everything and anything, you see that custom it's being it's going away. Like people say, yeah, my mom should know this, that one of her sons died or something. So it was kind of an old thing. It's changing, but it's still there, especially in the people that are 40s, 50s, 60s. They protect a lot from information about death or those kind of things from the older ones.
Okay. Another thing that seems to be prevalent in many cultures is what we call filial piety, which is a hierarchical pattern of who is the decision makers, what family members are responsible for decisions. And lots of times that moves in contrast to our autonomy, feeling like the specific patient is the decision maker, but because of these hierarchical patterns, other family members by culture are assigned. Do any of your religions have, or I'm sorry, any cultures have any of that filial piety restrictions?
I think it's more of a culture than a religion based, this answer, but I think our particular culture has more of a patriarchal hierarchy, where the father is the head of the household, and if his parents are living in the house, then it would be his father that would be the head of the household, would be the decision maker, per se. But I think that being said, I think, and it goes back to how, what kind of socioeconomic status you have and how educated I think the female is, or the mother of the household is. Because I think that even though there's a patriarchal hierarchy, I think that she plays a big role or influence. If the more educated she is, she influences kind of the way he thinks. But I think the main reason in India why it is patriarchal is for that sole reason, not sole reason, but a major reason is because the woman is not educated.
Okay. In past, there's been some lack of trust due to historical persecution or oppression of different patients of different ethnic groups. Does any of y'all know of anything within your culture that might be, may have played a little part that may cause people to be a little distrustworthy of medical professionals?
This is me talking as part of the Jewish religious community. Basically, there's three big branches that you have. You have the Orthodox, you have the liberals, and in between you have the conservative movement. The more you go towards the Orthodox movement, the more you might see that the Orthodox Jew goes to a Jewish physician. And I actually raised this question at some point, and it has to do some with knowing the traditions and the limits and what they can do, and not encounter that with other doctors, that thing where you might feel uncomfortable or trying to stop certain things. The Orthodox doctor will know exactly what your beliefs are, but it is said that if the doctor is trustworthy, they will go to any doctor if they have their trust. Like at some point you might need to earn it, especially with the Orthodox community. But it's not that they cannot go, or they have to feel that the doctor is trustworthy. If they can trust him, there's not a problem. But they definitely will feel much more comfortable going with a doctor that would know their culture, their traditions, and the limits that they have regarding medicine.
I think for me personally, I think in Nigeria there's not so much of an issue with this, but coming to America, I know it still holds. I mean, in America, I'm seen as a Black American. Most people probably won't know my background growing up. So usually, and I see this a lot working with patients, especially the elderly, there still is a lot of mistrust here and there. And I mean, a lot of it dealt with, issues like Tuskegee experiments and that sort of thing. So I still think it is quite an issue for some people.
I know that being from Louisiana and having my parents and my grandparents involved in the plantation system for a while, and I'm really one generation out of sharecropping myself, and so it's there was a distrust that is still there, especially among the older generation. And actually, there are two lines. One is the generation who tend to be older, who believe that going to a Caucasian physician is better because they're perceived as being more intelligent. And then there's the line that will only see a Black physician because there is that trust. They feel that they won't be given wrong medications or be experimented on as well. And then you also have the line of, as far as myself, and Louisiana tends to be very spiritual. And in my family, there were a lot of, some people call them traiteurs or herbal doctors. I had a lot of voodoo priestesses in my family. And even myself, even when I was sick, sometimes I wouldn't be brought to the doctor. I'd be given something that, it was an herb that grew on the side of the road, and it was called McGhee. And you boil it, and they'd they pour Seagram 7 in it, boil it, and they throw blankets on you, and your grandmother comes and say a prayer, and you sweat it out, and the next morning you're fine. And so you have to fight that as well, especially with me, since I'm fighting with them with modern medicine and what they want to do as well. And so when I do that, it's kind of develops a mistrust in me because they see me going against kind of my heritage, and see me maybe connecting more with the modern medicine, which they don't trust. They don't believe to work. And so those are some of the roadblocks that are still there.
And that brings me to another question that I was going to ask the panel, and that's that, patients seem to combine their pharmaceuticals that we in modern medicine prescribe them with culturally based herbal medications. Does anyone else have any examples of how their culture might mix their traditional medicine with what we see as modern westernized medicine?
Yeah, definitely.
Let's share a few examples about that, maybe.
In Vietnam, they have the doctor's office, you have the pharmacy, and then you have the herbal store.
Yeah.
Where you go and you tell them what's wrong with you, and the person at the herbal shop will tell you what to take.
Yeah.
I had an aunt a few years ago who was told she was told ovarian cancer. I don't really believe it, but she went for her treatments at a hospital, but then she also drank a tea that they told her would help, and then she did fine. And so they do a lot of that in Vietnam, where you go to the hospital and it's very Western. The medicine is very Western, but then they also have these whole shops and these herbal specialists that will supplant that.
In Peru, and I think in a lot of parts of Latin America, you have like the curandero, and that would be like a kind of doctor that people go to, but it's so spread out that you can buy it in the market, those kind of herbs. Like my grandmother knew a lot of it, and for every single thing that me or my sister or any of my cousin would have, she would have a certain herb for it, and she would just boil it and make. They taste horrible, by the way. but actually, I think it worked a lot. So when I came here doing family medicine residency, I was very involved into complementary and alternative medicine. I actually have my boards in complementary and alternative medicine because I wanted to find similarities, and you can find a lot if you go a little bit into cat's claw. I had a lot of difficulty finding the name, because you would learn it in your childhood, like by a local name, or what did it serve for. Like if you have gallbladder stone or kidney stone, you would have an herb that is called a stone crusher, and you will drink it. But I wanted to see what's the principle of it and try to find it here, and you actually find a lot, and they're basically for the same purpose. So there's a lot of it, and you can find it anywhere in the markets, or it's very, very widespread.
I think in Mexico also the herbal side of medicine is very prominent. The only problem in Mexico is that here in the United States there's a lot of regulation of what exactly you can say a product does. And then in Mexico, for some reason, uña de gato can cure diabetes, heart failure, and pretty much everything. And it's on the label. It's presented to you as such. So there's a problem where a patient thinks that he's being treated, and I'm saying, some herbal medications are valid and provide some help, but you, as a person from that country, when you have a patient that comes to you, you have to tell them, okay, this is fine, some of this herbal medication is good, but this is also what I recommend. You need to see this part of medicine also. And I think touching